This is the Baker Act Training, Minors, Module 2. In this module, I'll provide an overview of the Comprehensive Child and Adolescent Mental Health Services Act. I'll review who has general authority to consent, treatment, etc., and discuss the disability of non-age and consent, and then specify the functions of a CCSU. It is estimated that 13 to 20% of children living in the United States, or approximately 1 out of every 5 children, experience a mental disorder in a given year. And an estimated $247 billion, that's billion with a B, is spent each year on childhood mental disorders. Because of the impact on children, families, and communities, children's mental disorders are an important part of public health issues in the U.S. To address these issues, Florida has established the Comprehensive Child and Adolescent Mental Health Service Act. Throughout the state, there are specific guiding principles that direct professionals on how to care for these children. The following slides will explain further. Studies indicate that the majority of mental illnesses begin before adulthood. In fact, 1/2 of all diagnosable cases of mental illness begin by age 14, and 3/4 begin before the age of 24. Changes in a child or youth's behavior, mood, ability to get along with others, or ability to learn new information may stem from mental, physical, or developmental problems. For this reason, a thorough assessment by an experienced professional is important in determining the cause of these difficulties. Learning that a child has a mental health or substance abuse problem and needs professional help can be painful or frightening for the child and their family or caregiver. The family and the child and the qualified mental health or substance abuse professional must work together to decide what evidence-based practice will be most effective. Mental illness can be difficult to diagnose in children for a number of reasons, including many early signs and symptoms of mental health problems look like part of normal child development, and it can be especially difficult to tell the difference when the signs and symptoms first start. Also, some of the same symptoms may be seen in a number of different diagnoses, and some mental health problems can occur at the same time.
Schizophrenia strikes young men and women, most often between the ages of 15 and 30, and sends them into a state of endless mental agony.
I think of it as an extremely tragic disease because it pulls the rug out from people, psychologically speaking, right when they're entering the time of their life. In schizophrenia, it's totally silent for up to 2 decades during infancy, childhood, and early adolescence. You have people who are valedictorians and the best athletes in school, the most popular individuals, and boom, they develop schizophrenia and everything changes.
In general, consider seeking professional advice if a child or adolescent shows the following signs or symptoms, such as feelings like having unexplained fears, acting sad or hopeless, having thoughts of suicide or wanting to die, being constantly concerned about physical problems or appearance, or losing interest in things that they did have enjoyment with at one time. Behaviors that need to be addressed include a need to clean things or perform certain routines many times a day, frequent attacks or attempts to harm other people or animals, frequent nightmares, unexplained changes in eating or sleeping habits, hurting oneself, breaking rules or laws without concern for others, using alcohol or drugs, any sudden changes in school performance, dieting or eating to an extreme, and other unexplained behaviors in behavior, mood, or thought. If there's a concern about problems with feelings and emotions, thinking, behavior, or the use of alcohol or drugs, talk with the child's pediatrician. Discuss symptoms and behaviors with the doctor to help rule out medical, vision, or hearing problems or problems with growth and development that might be mistaken for a mental health or substance abuse problem. Should none of these possible problems be identified, then the physician should suggest a mental health professional experienced in diagnosing childhood mental health, substance abuse, or learning disorders.
The compulsion is the actual physical doing to relieve these thoughts.
If your obsession is, my hands aren't clean enough, the compulsion would be maybe to wash your hands.
They can spend 2-3 hours just washing their hands.
Hoarding garbage, counting, checking. There's a whole myriad of different compulsive rituals.
It's like having like a bully that's there with you 24 hours a day.
Some of the most common diagnoses for children and adolescents are attention deficit disorder with or without hyperactivity, depression, anxiety disorder, including post-traumatic stress disorder, oppositional defiant disorder, conduct disorder, substance use or abuse, and schizophrenia. Target populations for child and adolescent mental health services that are funded through the department, based of course on the extent to which resources are available, include the following groups of children and adolescents who reside with their parents or legal guardians or who are placed in state custody. These include children and adolescents who are experiencing an acute mental or emotional crisis, who have a serious emotional disturbance or mental illness, who have an emotional disturbance, or who are at risk of emotional disturbances.
At school, he would put shards of glass from the playground when there were some in his mouth because your brain told you to do that, and pretty scary things like that.
I had certain bad thoughts, like my parents would get kidnapped, I'd get kidnapped, I'd fall through a drain pipe, my family would get hurt, and I had lots of habits from those thoughts. And one of those habits would be in the kitchen. I put a knife into my chest, or into my ass, and then I'd take it out, and I'd feel relief for a second, and then I'd have to do it over and over again. Feel relief for a second, then over and over again.
Suddenly, boom, and it would just become like Jekyll and Hyde, a different person. He would throw things, spit, bite. There were expletives. Every swear word in the world would come out.
You fucking bitch, you fucking asshole, you smell like shit, you fucking asshole. And it made me cry and my parents cry. And even my sister Ainsley cry.
Ainsley, what's it like living with a brother who has OCD? Tell me about it.
Well, it's kind of pain. He does things that his OCD makes him do that I don't like when my friends are over.
I'd bite, and my dad had to wear work gloves because when I got restrained, because I used to spit, bite, and scratch only in rages, but not in real life. And I don't mean anything I say in rages, I swear, but I don't mean anything I say.
Within the Baker Act is Florida Statute 394.490, the Comprehensive Child and Adolescent Mental Health Services Act. It contains guiding principles for the child and adolescent mental health treatment and support system, and it is the intent of the legislature that the following principles guide the development and implementation of the publicly funded child and mental health treatment and support system. First, the system should be child-centered, family-centered / adolescent-centered, with the needs and strengths of the child or adolescent and their family dictating the types and mix of services that are provided. Families and or surrogate families should be active participants in all aspects of the planning, selecting, and delivering of mental health treatment services at the local level, as well as being involved in developing statewide policies. And the system of care should be community-based with accountability, local services, and the responsibility of management and decision-making resting again on the local level. Mental health programs and services should support and strengthen families so that they can more adequately meet the mental health needs of their child or adolescent. Children and adolescents should receive services that are integrated and linked with schools, residential child caring agencies, and other child-related agencies and programs. Services must be delivered in a coordinated manner so that a child or adolescent can move through the system of services in accordance with the changing needs of that individual. The system should provide timely access to a comprehensive array of cost-effective mental health treatment and support services. Children and adolescents who receive these services should receive individualized service and guided by an individualized service plan in accordance with unique needs and strengths of each child or adolescent and their family. Through an appropriate screening and assessment process, treatment and support systems should identify as early as possible children and adolescents who are in need of mental health services and should target known risk factors. Minors should receive services within the least restrictive environment, most, quote, normal environment that is clinically appropriate for the services and the service needs of the child. Mental health services for minors must be provided in a sensitive manner that is responsible to cultural and gender differences and special needs. Mental health services must be provided without regard to race, religion, national origin, gender, physical disability, or other characteristics. Lastly, the delivery of comprehensive child and adolescent mental health services must enhance the likelihood of positive outcomes and contribute to the child or adolescent's ability to function effectively at home, at school, and in the community. An older adolescent should be provided with the necessary support and skills in preparation for coping with life as a young adult. An adolescent should be assured a smooth transition to the adult mental health system for continuing age-appropriate treatment services. Community-based networks must educate people to recognize emotional disturbances in children and adolescents and provide information for obtaining access to appropriate treatment and support services. Each service district of the department is to develop a detailed implementation plan for a district-wide comprehensive child and adolescent mental health information and referral network. The Children's Mental Health System of Care is a collaborative network of services and supports in each circuit that in partnership with families is intended to help children diagnosed with serious emotional disturbances live at home, do well in school, and successfully live in the community. The system of care is designed around the guiding principles we've just discussed, and each circuit is responsible for fulfilling the mission. Services are delivered both through contracts with public and private service providers and by purchasing services on an individual basis. Some services can be accessed directly, such as in the case of crisis care and certain outpatient services, and others are available through staffing processes such as multidisciplinary service planning teams and child-specific family teams. Applications for residential services must be reviewed and approved by the circuit office. It is the intent of the legislature that the service planning process focus on individualized treatment and the service needs of the child or adolescent, and that the principles of the service plan process assist the family and other caregivers in developing and implementing a workable service plan for treating the mental health problems of that minor. The service plan must include the list captured here on this slide, and the service plan shall be developed in conference with the parent or legal guardian, and if that individual believes that the service plan is inadequate, then they may request that the department or its designee review and make recommended changes to the plan. The service plan is to be reviewed at least every 90 days for programmatic and financial compliance. The department shall develop standards for case management services and procedures for appointing a case manager. It's the intent of the legislature that case management services not be duplicated or fragmented, and that such services promote the continuity and stability of a case manager assigned to a child or adolescent and their family. The case manager should provide advocacy services, link service providers to a child or adolescent and their family, monitor the delivery of services, and collect information to determine the effectiveness of the service and treatment. Different laws, rules, and court opinions apply to different youth based on their legal status and current life circumstances. Below is a list of some examples of the different classifications. Generally, minors are considered incompetent to consent to their own mental health or medical treatment, but they can often consent to substance abuse treatment. Parents do have that priority in terms of general consent for treatment of a minor. If a parent dies, then the surviving parent would be the guardian. If the parents divorce, then guardianship goes to the parent awarded custody. Custody is now referred to as the parental responsibility. If the parents are given joint custody, then both parents are guardians. And if neither parent is granted custody, then neither is a guardian. If a child is born out of wedlock, then the mother of that child is considered the guardian unless the court order states otherwise. Chapter 61 of the Florida statutes governs all issues related to dissolution of marriage, child support, and child custody. Of importance to us is the fact that this chapter states that access to documents and information pertaining to a minor child's medical, dental, school, and other records cannot be denied to either parent. The only exception is if a court order specifically revokes such rights. Both parents also have the right to in-person communication with a minor child's medical, dental, and educational providers unless such contact is specifically prohibited by a court order. Sometimes the birth parent or adoptive parent, legal guardian, or legal custodian is not available to consent to medical treatment. In these circumstances, the treatment provider must maintain documentation that a reasonable attempt was made to contact the person with the power to consent. Medical care or treatment includes ordinary and necessary medical and dental examinations and treatment. It excludes provisions of psychotropic medication, surgery, general anesthesia, or other extraordinary procedures for which a separate court order, power of attorney, or informed consent is required under law. The prioritized list shown here of persons who may consent for minors when the person with the power to consent cannot be contacted in a reasonable time. Note that this list does not apply to minors under the supervision of the Department of Children and Families or under the Department of Juvenile Justice.
Sally is 15 years old and resides in the care of her grandmother. She needs medication for her asthma and for attention deficit disorder. The grandmother is not Sally's legal guardian. Can her grandmother provide consent for Sally to take both medications? Sally's grandmother may only provide consent for the asthma medication because the medication for ADD is a psychotropic medication. See previous slide to review exclusions for medical treatment when consent from a parent or guardian is not available.
In the absence of parental consent, a licensed physician may render emergency medical care to any minor injured in an accident or suffering from an acute illness, disease, or condition if a delay in providing treatment would likely endanger the minor's health. Such emergency medical care can only be administered in a state-licensed hospital or in a college health facility. Paramedics, emergency medical techs, and other emergency medical service personnel may render treatment prior to hospitalization, provided such care is consistent with Florida Statute 401. When parental consent cannot be obtained for one of the following reasons, then the parent, guardian, or legal custodian must be notified as soon as possible after administering the emergency medical care. The sick or injured minor is unable to reveal the identity of their parents, guardian, or legal custodian, and such information is unknown to anyone accompanying the minor to the hospital. Or if the parent, guardian, or legal custodian cannot be immediately located by phone at their place of residence or their business. Hospital records must contain the reason consent was not initially obtained and a statement from the attending physician explaining that the immediate emergency medical care was necessary for the minor's mental or physical well-being. The hospital records must be available for inspection by the person legally responsible for the minor. There are conflicting state laws, case law, and court rules governing the admission and treatment of minors. For example, Florida Statute 743 recognizes minors who are 17 years old or younger who no longer have that disability of non-age, that is, those that are married, divorced, pregnant, and unwed, or adjudicated as an adult.
Question: when does someone grow up? It's a philosophical question. It could have to do with the life experiences someone has and the wisdom they gain from those experiences. It's also a scientific question. Being a grown-up is related to how mature you are, or more specifically, how developed your brain is. For years, scientists have known that the human brain is not fully developed until around the age of 25. Although we have all of our gray matter, which includes cell bodies and neurons, nerve fibers, and support cells, by the time we're 12, it takes more than a decade for all that matter to become fully wired and pruned for efficiency. So this is a process called neuromaturation, and scientists believe it's the reason why teens in general, share some common behaviors. So I'm talking about things like sensation-seeking, risk-taking, and needing to be accepted by their peers. So the teenage brain is going through a lot of critical transformations, particularly in the prefrontal cortex, which is one of the last areas of the brain to fully mature. It's responsible for executive functions like goal setting, paying attention, motivation, planning, understanding consequences, and having self-control. So the fact that these functions are underdeveloped is part of why teenagers tend to engage in risky and impulsive behaviors like experimenting with drugs and alcohol, having unprotected sex, speeding, and doing stupid things that drive their parents a little cray-cray. Right around puberty, the brain's dopaminergic reward centers also become highly active and slowly wither out as you become an adult. This makes teenagers especially prone to peer pressure. The reward centers are super sensitive to social approval or disapproval. One study found that a 20-year-old was 50 50% more likely than a fully grown adult to do something risky if two peers were watching. Scientists have also found that brain circuitry responsible for emotional responses are changing, making teens more responsive to emotionally loaded situations than both children and adults. So teenagers might seem like they're being really dramatic with their emotions, but the reality is they're experiencing them very intensely. They're also experiencing a lot of feelings for the first time, which can exaggerate their intensity further. Intellectually speaking, the capacity to learn will never be as high as it is when you're a teenager, and their intellectual power and ability to do mental tasks is already right up there with adults. So I think there's a tendency for grown-ups to become impatient and dismiss teens as stupid, immature, and incapable, but it helps to remember that teens are undergoing a lot of neurodevelopment. It's all a part of the natural process where a human moves from dependence on caregivers to an independent, fully functional adult.
A circuit court removed the disability of non-age of a minor 16-year-old Janice. How does this affect the minor's rights to make her own legal and medical decisions? A circuit court has jurisdiction to remove the disabilities of non-age of a minor aged 16 or older residing in this state upon a petition filed by the minor's natural or legal guardian, or, if there is none, by a guardian ad litem. The court shall consider the petition, and if satisfied that the removal of the disabilities is in the minor's best interest, shall remove the disabilities of non-age and shall authorize the minor to perform all acts that the minor could do if he or she were 18 years of age. Lisa is 15 years old, unmarried, and pregnant. Is she legally considered a minor? An unwed pregnant minor may consent to the performance of a medical or surgical care or services relating to her pregnancy by a hospital or clinic or by a licensed physician, and such consent is valid and binding as if she had achieved her majority.
Because the Baker Act contains few specific references to minors, and this law must be followed in the context of coexisting statutes and case law, it's important for mental health professionals and agencies to have legal counsel review all policies and procedures. When consent to admission and/or treatment is sought for a minor, it is essential that the mental health professional consider whether the consent was freely and knowingly given. As discussed in Module 1 of this course, the Baker Act defines an individual 0 to 17 years of age as a minor. You'll find the term minority or minority disability in other areas of the Florida statute, specifically 743 and 744. The term is a preferred legal term, and it encompasses the full range of persons who fall into underage categories, such as children, infants, juveniles, young person, pupil, etc. Minors aged 13 or older may consent to limited outpatient crisis intervention services that do not include psychiatric medications. These services must be provided by a licensed mental health professional or state licensed mental health facility. Services are limited to 2 outpatient visits during any 1-week period. When any minor aged 13 years or older experiences an emotional crisis to such a degree that they perceive the need for professional assistance, then they have the right to request, consent to, and receive mental health diagnostic and evaluative services provided by a licensed mental health professional or in a mental health facility licensed by the state. The purpose of such service shall be to determine the severity of the problem and the potential for harm to that person or others if further professional services are not provided. Outpatient diagnostic and evaluative services shall not include medication and other somatic methods, adverse stimuli, or substantial deprivation. Such services shall not exceed 2 visits during any 1 week period in response to a crisis situation before parental consent is required for further services. And it may include parental participation when it's determined to be appropriate by that mental health professional or the facility. Another circumstance where the disability of non-age is removed is when a minor, age 13 or older, experiences an emotional crisis to such a degree that they perceive the need for professional assistance, then they have the right to request consent to and receive outpatient crisis intervention services that include individual psychotherapy, group therapy, counseling, or other forms of verbal therapy provided by a licensed mental health professional or in a mental health facility that's licensed by the state. Such services do not include that medication and other somatic treatments, aversive stimuli, or substantial deprivation. It's the same pattern of services are not to exceed 2 visits during any 1 week in response to a crisis situation before parental consent is required for further services and may include parental participation when it's determined appropriate. Parents or legal guardians of a minor are not liable for payment for these outpatient diagnostic and evaluative services or outpatient therapy and counseling just mentioned unless such parents or guardians participate in the outpatient diagnostic and evaluative services or outpatient therapy and counseling services. And then they're only responsible for the payment for the sections in which they participated. Another provision is that no licensed mental health professional is obligated to provide services to minors in accordance to the right to receive services under this section. Provision of such services shall be on a voluntary basis. Most ongoing treatment of children and adolescents is provided on an outpatient basis in homes, schools, or in the community. When this is not possible, Florida has established residential treatment centers to provide mental health assessment and treatment services to young clients who meet established clinical criteria. The rights of children must be safeguarded while residing in residential treatment centers. Children must be informed of their legal and civil rights, including the right to legal counsel and all other requirements of due process. A facility may receive for observation, diagnosis, or treatment any person aged 17 or under for whom such application is made by their guardian and only after a hearing to verify the voluntariness of the consent. Express and informed consent for admission or treatment given by a patient who's under the age of 18 shall not be a condition of admission when the patient's guardian gives express and informed consent for that admission.
Bill is 17 years old and was adjudicated as an adult. He is under the supervision of the Department of Corrections. Under the law, is he considered a minor or an adult? Legally, Bill is an adult because he was adjudicated as an adult and is under supervision by the Department of Corrections. The disability of non-age is removed because of his adjudication and supervision status. However, Bill cannot provide his own consent to voluntary admission under the Baker Act because of his age. He needs the consent of his parent or legal guardian and a judicial hearing confirming the voluntariness of his assent.
Crisis Stabilization Units, or CSUs, are receiving facilities that receive public funding. They may screen, assess, and admit persons on either voluntary or involuntary status. In addition to 24-hour observation, clients receive all necessary treatment, including prescribed medications. CSUs charge fees on a sliding scale, but must provide services regardless of a client's ability to pay. Florida established crisis stabilization units for children and adolescents, or CCSUs, through the community mental health centers. CCSUs cannot exceed 20 beds, and the purpose of a crisis stabilization unit for children is to stabilize the minor and redirect them to the least restrictive, most appropriate community setting consistent with their needs. There are over 50 crisis stabilization units in the state of Florida, some specific for children's crisis stabilization. To see the full list, look at our resource section on the home page of this course. Each person entering a facility must be asked to give express and informed consent for admission and treatment. If the person is a minor, then the express and informed consent for admission and treatment must also be requested from the person's guardian, as in the other situations. Express and informed consent for admission and treatment of someone who's under the age of 18 is required from the person's guardian unless the minor is seeking that outpatient crisis intervention services. Every program which serves persons under 18 years of age shall define in local program standards the services and supervision to be provided to the children. Minors under the age of 14 years old shall not be admitted to a bed in a room or ward with an adult. They may share common areas with an adult only under direct supervision by units. This means visual supervision. Minors who are 14 years of age or older may be admitted to a bed in a room or ward in the mental health unit with an adult if the clinical record contains documentation by a physician that such placement is medically indicated or for reasons of safety. This shall be reviewed and documented on a daily basis.
Gina, 16 years old, was admitted to a psychiatric unit at a local hospital. She is sharing a room with a female adult because pediatric beds are not available. Under the Baker Act, can Gina share a room with an adult? A minor, 14 years or older, may be assigned to share a room with an adult on a psychiatric unit if the admitting physician documents that such placement is necessary for medical or safety reasons. The attending or on-call physician must review the placement each day and document its necessity in the case record. Since Gina is 16 years old, she could share a room with an adult if the attending physician documents that the placement is necessary for medical or safety reasons. Note: a minor under the age of 14 admitted to a hospital may not share a room or common areas with adults on a psychiatric unit. If a minor is sharing a room with an adult, then they will be assigned a one-to-one, which means that a mental health technician will be with that minor 24 hours a day and supervising them.
And of course that just makes you depressed. So I had decided like life wasn't worth living. When I was 16, I tried to kill myself. I took a bottle of my medication, clomipramine, and I just kept swallowing the pills. And I really didn't want to die. I just wanted to be normal. I just wanted everything to go away. So I just took the pills, and after I took them, I felt really bad and really dumb. So I told my dad eventually, and I went back to the hospital.
This concludes the coursework for Module 2. Do you know the Comprehensive Child and Adolescent Mental Health Service Act and its role in mental health services? Who has general authority to consent to treatment? What is the disability of non-age in relation to consent? And what is a function of CCSUs? If you do not feel comfortable answering these questions, you may want to go back and review this module again. If you feel that you do know the answers, then you may proceed to the Module 2 Knowledge Review. To complete the Knowledge Review, go back to the M2 tab and click open the Module 2 Knowledge Review. After completing the Knowledge Review, you may decide that you need additional study of this information. If so, return to the beginning of the module. If you correctly answer 8 out of 10 questions on the Knowledge Review, you may proceed to the Module 3 M3